Welcome to QSNICH National Institute of Child Health. Today, first I would like to introduce my team. So on my left-hand side is Dr. Warakan, who's helping with the echo. And on my right-hand side is going to be Dr. Priya, the guest from India, and my scrub nurse, Kun Prao Down. And the next, we're going to introduce the history of the case by Dr. Nuta, our fellow. Please.
Good afternoon, everybody. Today, the first case we plan to do that intervention is PNVST closure. He is a 13 years and 3 months old boy, weighing 30 kg, and the VST was diagnosed at 6 months of age. And on examination, saturation is 100% in air. There is a slightly active precordian, and apex peak is palpable at the left foot intercostal speed mid-clavicular line. There is a normal first and second sound, and grade 3/6 pansystolic murmur is heard. Maximum intensity at the lower left sternal edge, and there is no diastolic murmur associated. This is his chest X-ray showing the mild cardiomegaly with plethoric lung fees, and his ECG was recorded as normal sinus rhythm with heart rate of 100 beats per minute. In transthoracic echocardiogram, we can see that there is a aneurysmatite of perimembranous VSD, left to right shunt, and measuring LV axis is about 8 to 9 millimeter in diameter, where RV axis is 4, and the interventricular septal length is about 8 to 12 millimeter in greatest dimension. The distance between the aorta and VSD is about 6 millimeter, and the VSD pressure gradient is about 84 millimeter mercury, and there is no aortic valve prolapse, no aortic regurgitation, but there is a mild tricuspid regurgitation noted, and slightly dilated left atrium and left ventricle, and there is a left arch and no coarctation of aorta. So our plan is first to do the transesophageal echo first and trying to close the VSD in retrograde fashion with MFO VSD device 68.
Thank you very much, Dr. Nuta. So, Dr. Akan, could you please show us the TE, please?
Yes, thank you, Nuta and Sisi. So, sorry that we didn't record the echo transthoracic, but this is esophageal recorded. So this is just as you can see, this is 0 degree of angulation, showing the VSD is here. So definitely this is aneurysmal type defect, and this is very membranous because, as you can see, it's very close to the tricuspid valve and together with the aortic valve. And one thing you can see here, the septal leaflet of the tricuspid valve is still moving freely, while you can still seeing the aneurysm very, very clearly here. So that's representing that part of the defect is actually not the septal leaflet of tricuspid valve. And here we angulate a little bit, clockwising a little bit more on the probe, just confirming again that the separation between the septal leaflet or tricuspid valve and the aneurysm. This view, again, you can see we angulate more on about 40 degree, showing the very close to the defect, the aortic valve, and also just confirm that this is aneurysmal type. So from here, we can see just maybe one exit here. And then we're angling more onto the 70 degree Here's the outflow tract on the right side, and here's the tricuspid valve. And in this view, it's very clearly that this patient got very obvious TR. That's probably because of the flow from the VSD through the tricuspid valve on this view. And then just showing again to the 180 at 120 degree something, showing that there is no AR, just trivial AR here, and it's away from the aortic valve in this view. But when I tilt a little bit more on that view, and as you can see, we see very clearly again the aneurysm of the defect here. So from echo, it looks as if we have the defect, which is quite close to the tricuspid valve, and that is kind of aneurysmal type. So in terms of the measurement, I will show you in a minute. So on this view, the measurement is about 8 millimeter at the LV entry, and the exit is about 3.7 millimeter with the length of about 7 millimeters. And in this view, about 124 degree, just confirm that the LV entry is about 9 millimeters, while the RV exit is about 4, and the length is about 10 millimeters. So that's all for me, CC.
Okay. So next we're gonna show the angiogram. This is our areocranial wheel and the true lateral wheel. You can see the perimembranous VSD with the pouch. The measurement, please. So this is a measurement from the AP wheel. The RV exit was 3.6 millimeter. The LV entry was around 10 millimeter, which is quite similar to the TEE. Lateral, please. And this is a measurement from the lateral. The maximum RVS was to 4.8, and the LV entry approximately around 10 millimeters. So we plan to use the MFO device.
Yes, CC, but couple of questions before we start. So first of all, I think, how about the QPQS?
QPQS was 1.7 in this
Okay.
patient.
And what's
And
the
very
real
low
indication then
PVR.
for closing it?
So the true indication is actually quite similar to surgical management of the VSD, which is QPQS more than 1.5. And this patient also have the problem with recurrent pneumonia. So I think this is the indication for this patient.
Thank you. And one more thing about TR. So any consideration on TR in this particular case? Because you have very severe TR, and some doctors may say, why don't you go for surgery? Why do you try to close the defect by the device?
So actually, it's very difficult to answer, but the flow from the TR actually causing from the jet of the VSD. So sometimes when we close the VSD, then the TR will get less than before. So what we are going to do is we'll try to open the disc, the first disc on the right side, and then we'll try to manage the right side, and then let's see from the TOE that the TR will getting better or not.
Okay, thank you.
Okay, so in this patient, because our VXS is actually around like 4.5 millimeters, so we are going to use the MFO device. We're gonna show you the device that we're gonna put in, which is the Kona MF device, multifunctional occluder. We can use this device for closing the PDA, VSD, and also coronary fistula, or also like collaterals. So the device will come in two parts like this, and then this is the part that's gonna be on the LV side, and this is the part that's gonna be on the RV side. And the good thing of this device is they have the screw on both sides, which means that you can actually deploy from the right side and also deploy from the left side. So we plan to use the S6 device. So the 6 is gonna be here, the diameter before the connection, and 8 is gonna be here, and the this is actually plus 2 each on each side. So the disc is depends on the size of the device. So we will look at the chart of the device. So this is the device. The dimension that I mentioned, 6 on the device that we're gonna use is D1 here, and 8 is the D2 here, and both this is actually 2 millimeter on each side. But if the device which is come in the number like 5, 7, 9, the device gonna plus 2.5 on each wing, and we get the diameter here is gonna be a little bit bigger, and the disc on the right side is gonna be similar to the disc on the left side.
Thank you, Sisi. So may I ask a little things? First, maybe why you choose 8/6? Any particular consideration on that?
So normally we will plus around like 2 to 4. It depends on the anatomy of the defect, and also the size of the aneurysm if the patient have the aneurysmal type of the VSD. So in this patient around like 4.5, I think D1 around 6 and D2 around 8. With the disc that around like 12 is actually fit enough for this kind of the patient.
Okay, thank you.
And this patient, according to the TE, we found that the patient has very severe TR. So we plan to deploy from the right side. So we will close the VSD and then exchange to the JR guiding, and then open the right disc first, which means that we need to connect the left disc with the cable and then deploy the right first. So we screw in as normal, and then we load it under the water. Make sure there was no air.
So routinely we do giving heparin, right?
Yeah, we give heparin around like 50 unit per kilo after we get the access. And can you show us the angiogram? Could you please change to the angiogram, please? Okay. So this is how we close the VSD. Normally, we close the VSD using the wire and try to close the defect. But in this particular case, they have a very huge aneurysm. So just the wire is not enough push to close the only wire close the defect. So we just use the JR catheter to help with the while we are closing. And then we place the wire in the LPA. And then introduce the JR guiding over the wire and place it in the alveoli. Make sure there's no air while we introduce the device through the JR guiding. So Dr. Rakan, I'm gonna deploy the device now.
Yeah, sure, please. So normally I will put the echo on the angulation is about 90 to 100 something in order to delineate the RVOT and also the VSD and the aorta at the same time.
Now we introduce the device to the JR guiding. So now we about to deploy the right disc of the device.
Echo, please.
We already opened the right disc.
Okay, you see the
So-
echo, right?
Yes.
Okay.
And then we actually pull everything back together.
Okay.
Can you show us the color also?
Yeah, I will. Which
I
view
just
you
want
want?
to see the degree of the TR also.
Yeah, but in this view looks fine, so I'll switch to other view which showing the TR previously. Actually, this is the view. So looks better, huh, Sisi? And 0 degree here. Wait for me. Yeah, I think you can pull back a little bit even more. Yeah, maybe more, a bit more. Okay. Yeah, so I think it's ready for you now to open the rest.
So now we about to open by fix the cable and then pull the JR guiding out.
Okay. The low pressure disc is on the right side And the high pressure, this is now on the left side as you plan to have, right?
Yes.
Okay. Now both this looks fine in the right position. And TR almost disappeared, as you can see here. Just trivial teeny tiny TR here.
Can we see the AP view also?
And here's the 120 degree showing that device is actually below the aorta, aortic valve. Yeah, to me it looks very beautiful. I'm happy without even LV angio. I'm quite happy to tell you that the position of device is very nice and it's okay for me.
Okay. So the device is actually attached
Oh, you
with the
release
screw
already?
and cable. So not yet. So we're gonna make sure that the long sheet is not too close to the device and then deploy.
Yeah.
Okay.
So you release already.
Stop for roll, please.
Can you move the pigtail, the catheter back a little bit? Okay, very nice. So just to confirm that there is no outflow obstruction on the left side, you see here, is it wide open? Trivial AR still there, and the residual shunt still here, but just a little. I think we quite happy with that, but we need to check also the auscultation. I mean, by listening to the murmur. And this is another view showing the valve, tricuspid valve is functioning very well without disturbances, no TS definitely, and the TR is getting even less. Okay, so here also very nice position, and this is 0 degree. Just reconfirm that the device sitting very nicely without disturbances of the tricuspid and aortic valve. So I'm happy with this CC.
Okay. So what we are going to do is we will check the LV angiogram after deploy the device.
So what do you think, CC?
I think it's look okay.
Yeah, it looked beautiful to me.
Okay. So the device sitting in a nice position without having the trouble with the aortic valve.
Okay.
And also maybe small leak through the device, which is not much. So we
Yeah.
are done.
So
Thank you very much for everybody, our team and also AV team.